So we have somebody who's very well qualified to speak to you today, and I'm really pleased that he's with us. And please help me welcome Jim Capretta.
Thank you, Paul. Well, good morning. What's the song? It never rains in California, but that's okay. It makes me feel a little bit more at home. So no, I'm glad to be here this morning. Thank you, Paul, for the very nice introduction. Thank you for having me here at UC Irvine. Never been here before, so I'm really pleased to be here. Beautiful, even with the rain. As Paul indicated, there's a lot to think about and talk about here in this subject. My background is in budgeting and healthcare, and so it's the intersection where there's lots of issues, lots of turbulence. Someone was just saying, well, it seems at the particular moment right now it's very turbulent, and I think that's true, but it's been turbulent probably for most of the time I've been in Washington. So it's just one of those issues where it never really goes away, and we're always in a constant conversation about how we're going to address some of these very complex questions. So I have these slides that I use to kind of keep myself organized and focused. And I'll use that to kind of walk through the points I want to make today, and I look forward to also some Q&A with you, because I know that'll be instructive as well. Okay, to kick us off, what is the bottom line issue here with Greece in the news and other things in the news around the world in terms of sovereign debt? You hear the word sovereign debt a lot now. You never used to hear about it. Well, it's just a new term for money the government owes to people outside the government. And this is our situation here in the United States. We are obviously entering into a new era with the amount of debt the United States government is going to be holding and owed to parties that are outside the government. If the chart went back all the way to World War II, you would see that there was obviously a very big spike in debt held by the public during World War II. We borrowed quite a bit of money, mostly from domestic lenders during that era, but it got paid off very gradually in the 50s and 60s and into the 70s. And then we had a period of rising deficits in the 70s and so on, but we've now entered a period with the financial crisis in 2008, 9, and 10, and the projections for entitlements going forward, where we may be entering a place of really serious debt accumulation. They could have serious implications for the economy. Now, the projections here have two parts to it. One is, and these are from the Congressional Budget Office, which is the part of the independent group that does estimates for the Congress. They don't report to the president. They report only to the congressional leadership. And they do two different scenarios that go out beyond the normal 10-year period, a little bit longer time period. They call one the extended baseline scenario. And this scenario essentially means really current law. Whatever is baked into current law, that's what they estimate, and they assume that plays out over the next 30, 40, 50 years. And under that scenario, one might look at this and say, it's bad that we're up in the 75% or 80% of GDP in terms of debt, but it's not cataclysmic because it's not spiking up like this one, okay? So you think, well, maybe if we can get to this kind of a line, it's survivable, okay? But then they have this other scenario, the alternative fiscal scenario. And why do they have that in here? That's because the difference between these two lines is reality and expectations. Okay? This line assumes that the entire balance of current tax law, which actually continues through 2012, will expire at the end of 2012, and we will revert back to tax rates that applied prior to 2001. Okay? So you always hear about the Bush tax cuts. Okay? This line assumes that all the Bush tax cuts, which have now been extended by President Obama, will expire at the end of 2012. This line assumes, and it assumes, frankly, that we will cut physician fees by 30% beginning in 2012, and do some other reductions associated with the healthcare law in the healthcare arena. This line assumes that those tax cuts will continue, that the physicians will continue to get paid at rates that are basically at today's rates plus inflation, and that some of the cuts that are embedded in the healthcare law will play out at a more moderate pace, okay, which a lot of people expect to be the case. So the difference between the two lines then is really between something that is barely sustainable here. This is already probably too high, and this line here, which is obviously unsustainable. Now, going a little bit closer to today's period, CBO did a very nice chart here that kind of gives a way of framing up the basic plans that are on the table in terms of how to deal with some of these things. And this goes out to, most of these are for 2021, but if you look at a historical basis over the last 40 years, the revenues to the federal government have been hovering at around 18% of GDP, okay? And spending has been just short of 20.8% of GDP for a deficit of, on average, of about 2.8% of GDP. This is a very, if we were in this kind of a range on a permanent basis, people would be worried and we'd be talking about deficits still, but it wouldn't be to the point of worrying about real dislocation. Now CBO comes along and says, okay, if we have current law with all the Bush tax cuts expiring and all the cuts in healthcare spending scheduled to occur actually happening, we will have revenue will actually go up in 2021 from the historical average of 18 all the way up to 20.9% of GDP. So that'd be about almost a 3 percentage point increase in tax rates, in tax collection. Outlays would be up somewhat, 22.8, but the deficit would be very, very manageable at 1.2% of GDP. Okay, but of course, that, as I said, that's the extended baseline scenario. Under the alternative scenario, you start to get a feel for why the problem will be, maybe perhaps bigger than these lines would indicate. Under the alternative scenario, revenues would be 18.4% of GDP, outlays nearly 24, and a deficit approaching 5% of GDP. So this is actually the difference between this and this is really the difference between sustainability and not. You can't really run 5% of GDP deficits on a permanent basis. The president's budget comes in and says, and this is important, let's keep revenues at about 19.3% of GDP. This is very important because even the president says that going to 20.9% of GDP in taxes is not acceptable because that would include huge tax increases on the middle class. So even he wants to extend a good balance of the Bush tax cuts. His spending, however, would be well above this baseline amount from CBO. He'd push spending up even higher to 24.2% of GDP, and so the deficit would still be about 5% of GDP. This is why a lot of people were saying his budget from for 2012 was didn't do enough on balancing the budget. Then the controversial budget from the House Republicans, called the Ryan budget, don't have it for 2021, but for 2022, close enough. They have 18.5% of GDP in revenue, 20.2% of GDP in outlays for a deficit of about 2% of GDP. So the difference here between these two budget plans is really where you see the partisan fighting going on in Washington. Okay, so here you have about a 4 percentage point difference in spending. Okay, in about a 10 years time, that's a big deal. That's what they're fighting a lot about. Okay, and then the president would take taxes up, just short of 1% of GDP above the Republican level. Okay. Now, we just had a huge fight over the summer about raising the debt limit. And it did some things to the budget that are worth just noting so you understand how they affect those numbers. These changes are baked into what CBO has under their current extended baseline scenario. All right, so the deficit, they call this agreement they reached over the summer the Budget Control Act. It raised the debt limit, and it did some spending reductions. Now, the deficit in dollar terms, not GDP terms, prior to that agreement, this is what CBO said. They said, well, the deficit in 2011 will be nearly $1.3 trillion. But because of those Bush tax cuts expiring and other things, it'll come down quite a bit. So by 2021, we'd be short of we'd have just about a $600 billion deficit in 2021. Now, this Budget Control Act did two things. It had a caps on discretionary spending. Okay? So they came in and said for the next 10 years, there's a category of spending in the budget called discretionary spending, which is appropriated spending. This is the money you spend every year on various accounts of the government. They put caps on them. That'll save, in these years, going out to 2021, about $182 billion in that year. Then they also said we're going to have a joint committee meeting right now, the so-called super committee, the 12 apostles. And they are supposed to come up with another $1.2 trillion. Okay? So these caps on discretionary spending saved about $1 trillion over 10 years. They said, okay, joint committee, you come up with another 1.2, unspecified. We don't know what it'll be yet. And if they did, if they don't make it, then we'll have a backup thing called a sequester, which I'll talk about later, that will automatically cut spending even more, especially in defense. Okay? And these numbers assume that the sequester will actually go into effect. Okay? So with that, you get the deficit down from $600 billion in 2021 to just $300 billion in 2021 from the Budget Control Act. The caps on discretionary spending and the automatic sequester, you could be down in this range. Again, a survivable number. Okay? Problem is that a lot of people believe that that's a pretty big, that's a sort of a hidden tax increase in that would be pretty consequential for a lot of people. In fact, if you look at extension of the 2012 tax law out to 2021, it's about $800 billion in additional revenue loss that would occur. Moreover, just keeping physician fees at their 2011 levels instead of going with a big cut, that'll cost another $60 billion in 2021. So again, if you add those numbers to this deficit, you're back above $1 trillion deficit again. Okay? So that's really where people are seeing the problem. Now, let's get into the meat of our discussion today, which is healthcare. Healthcare is at the center of this entire conversation, and really it's because of this two charts, this one and the next one. The CBO, again, CBO does lots of useful things, but this is, again, from them, and it's a very useful measure of what's called excess cost growth. And what they did is they looked back at different programs, Medicare, Medicaid, non-Medicare and Medicaid in the total health system, and they compared the per capita growth of those programs on a per-person basis relative to per capita GDP growth, which is a good proxy for sort of revenue, income, our ability to pay for things. Okay? And they said, well, how does it compare on a long-term basis with that number? And over a very long period of time, going back 40 years, you have, for Medicare, it's gone up on average 2.4 percentage points faster than per capita GDP growth. Medicaid has gone up 2 percentage points faster. Other health spending 1.9, and the total system 2 percentage points faster. Now, in more recent years, just going back to 1990, the number is down somewhat. Medicare 1.6, Medicaid 1.1, the total system 1.5. But still, this is one of those things, where Herb Stein, has a saying, paraphrased many times, with unsustainable trends come to an end, right? And this is one of those unsustainable trends that hasn't yet come to an end, okay? Because if you continue to pay more and more of your income toward health spending, eventually it bumps up into something. Consumption you need to have in another area, or you can't just spend the entire economy can't be people taking care of other people. So this is one of those things that feeds into every aspect of American life. It affects budgets. It affects household budgets as well as government budgets. And this is really the reason why people are feeling the pinch from health spending. Add to that the fact that we are going through an unprecedented demographic transition, not just in this country, but around the world. And between 2010 and 2030, next 20 years or so, we're going to go from 41 million people age 65 and older to about 71 million. Okay? So 30 million more people in this category over a 2-decade period. It's a huge change. We've never experienced anything like this before, and it'll have dramatic implications for our budget as well as our healthcare system. You put that all together and you end up with this, which is sort of what people call the big three. There's 3 programs, now kind of 4, that are in this category. Social Security, which is of course the pension system for the elderly plus disabled, Medicare, and then Medicaid plus the healthcare law's new subsidy structure. Okay? For just these 3 categories of entitlement spending, back in 2000, we spent about, of course, the new healthcare law wasn't in effect then, but we spent about 7.5% of GDP on these 3 programs alone. Remember, the total budget is something like 20. Okay, so 7% of GDP on these 3 programs alone. By 2035, which seems like a long time, but maybe is not that long, it's going to be approaching 16% of GDP. Okay, and this assumes pretty aggressive implementation of all the new healthcare laws spending cuts, which I'll say in a minute why I don't think that's going to happen. So even under the best of scenarios, we're going to have a doubling of the amount of resources devoted to just these 3 programs in our budget over the next, a quarter century. That's a big deal. This is really why there's lots of pressure inside our budget. Okay, let's talk about the healthcare law quickly. This is the final cost estimate that was done on the healthcare law by the Congressional Budget Office in March of 2010. Obviously, you probably all remember it was a very contentious time, and this proved to be a pivotal piece of information. This was, that the healthcare law not only covered everybody in some fashion, but it did so while bringing actually the federal deficit down instead of up. Okay, and the bottom line number was $124 billion over the period 2010 to 2019. It was broken down into a couple of subdivisions. The coverage provisions, how much the Medicaid expansion, the new premium credits that are going to be available through the exchanges, some of the other spending provisions, $936 billion plus some miscellaneous items, another 30. The Medicare and Medicaid cuts, which we'll talk about, $450 billion roughly in cuts. Something called the Class Act, which is now no more, $70 billion, and tax increases of about $563 billion. So the net effect, according to CBO, was 124. This was a major talking point pushed by the proponents of the bill to pass it, and they had a CBO estimate saying, hey, this thing is going to actually reduce the deficit. Now, there are people like me who are looking at this thing, scratching our head a little bit, thinking this is maybe not quite, you got to dig into this a little bit more to understand what's going on. And a couple of things I think were worth noting and still are worth noting. One of them was the Class Act. This $70 billion number was instrumental. Remember, if this $70 billion number wasn't in there, this number dropped to 54, and the 54 was very backloaded. So what is the Class Act? Class Act was the long-term care insurance program that was voluntary. Basically, it was unrelated to the rest of the provisions of the healthcare law, but it said essentially that you could sign up for a new long-term care insurance program if you paid premiums for 5 years, you'd be entitled to benefits. Okay? By definition, when you do that, you have a period of time where there's the appearance of a surplus because people are ineligible for any benefits for at least 5 years. So you have payments coming in and a trickle of benefits going out. Okay? So within a 10-year time period, it looks pretty good. The problem was that everybody who looked at the program said this thing is not going to work out very well. That it's because it's voluntary, it's going to have severe adverse selection, that the people who tend to sign up for it will be people who anticipate needing the benefit, that the premiums are actually quite high. And so beyond the 10-year window, it was very likely to flip the other direction, even CBO said so, and be something that cost a lot of money rather than save money. When all is said and done, the administration looked at this program every which way, trying to figure out a way to run it in a way that wouldn't break the bank in future years. They couldn't find a way to do so, so they themselves pulled the plug on it about 2 weeks ago. So now that $70 billion is now gone. Okay. Now the other things that are in there that are sort of worth noting, there's something called the Independent Payment Advisory Board. I'm sure a lot of you have heard of it. It's in charge. It's got to cap the growth on Medicare, but it can only recommend more provider payment reductions. We'll talk about that in a minute, why that's maybe not a realistic expectation. Then there are the Medicare cuts for Medicare and the PPACA. Here, this is what some people might refer to as double counting. Basically, you have some reductions that are occurring in the Medicare program that are then financing the healthcare law, but they're also being used to pay for future Medicare benefits. Okay? So you say, and the way this works is because we have two different books in the federal government. We have a trust fund for Medicare, and we have the accounting books for the budget used to pass the healthcare law. They're separate. Okay? So the same money that is used to cut Medicare to pay for the healthcare law also, at least on paper, appears to make the Medicare trust fund look like it has more reserves, and you can pay future Medicare claims out of it. Okay? The truth is, though, you end up spending the same money twice. The budget is worse off because you saved a certain amount of money, but you actually spent it on two different things. Okay? So a lot of people looked at that and said, hey, this isn't going to be a very good long-term outcome. And then finally, we went through this entire exercise, but the one part of Medicare that didn't get fixed was the physician fee schedule. That, you did all these cuts, all this puts and takes and so on, but we still have a $300 billion hole in Medicare physician fees. So you did all these cuts in Medicare, spent it on some other things, and you still have to find $300 billion for this. A lot of people are expecting that $300 billion eventually just to be added to the deficit. Okay. So then if you do what I do, which is take some of that money out and say, okay, here's the CBO estimate of the deficit of the deficit reduction from the healthcare law, from that original March 2010 estimate. Okay, so this is why those annual amounts, you add them all up, it adds up to $124 billion. But if you take out the Class Act, it's not quite as rosy. It's a little bit closer to neutral. And then if you take out the Medicare HI savings, in other words, you say, look, you can't count the Medicare hospital insurance savings both for Medicare as well as the new healthcare law. If you take that out, then you see that this thing is actually going to be a big deficit increaser, not a deficit reducer. Okay, a couple more things quickly. They also said that the healthcare law is going to reduce the deficit quite substantially beyond the first 10 years. And I'm not so sure that's going to be the case because of these four provisions. There's something in the law called the high cost insurance tax. This was the tax that's imposed on premiums offered by employer plans or just individually owned plans that exceed a certain threshold, $27,500, which seems very high, for family coverage in 2018. Now recall that this doesn't start till 2018 because there was a big brouhaha with the unions about this. Turns out that the plans that would be hit the most by this are probably union negotiated plans from manufacturing industries with an aging workforce. Okay, so think Upper Midwest, Pennsylvania, etc. Okay, and they weren't all that keen on this provision, and so it got delayed to 2018. But then once it gets imposed in 2018, that threshold, that 27.5 and that 10,200, will grow very slowly, actually, relative to healthcare spending. It'll grow at the CPI rather than healthcare costs. Okay, so it won't hit anybody for a while, but then all of a sudden it's going to basically hit everybody. So it'll be a big tax increase in the second decade if it's allowed to stand. Let me talk about, let's skip this one and just come down here to this. Medicare Provider Productivity Improvement Factor. This is the big one. This is the one I think it'll affect a lot of you here in the audience. This is a permanent annual reduction in the inflation increases for hospitals, nursing homes, hospices, home health payments. It differs by payment by service category, but it's on average around about 0.5 percentage point. So you all know how Medicare works. Medicare gives a certain payment per diagnosis. That's inflated every year by an input measure. Okay, they measure what input costs are to these various providers. And the new law says that what we're going to do, instead of giving a 3.5% increase for these input costs next year, it'll be 3. okay? And it'll be 3 next year, and then the year after it'll also be 3 instead of 3.5, and the year after that, and so on and so forth. The compounding effect of this particular provision is very dramatic over the long run. This will actually bring Medicare's payment rates for these institutional providers well below what Medicaid is expected to pay. So this is a big deal. Finally, I would just note that the credits in the exchanges, these are the subsidies that go to people who get health insurance through the new exchanges. This is the way they cover a lot of people through the exchanges. They give them a new subsidy from the federal government that offsets a part of their premium, okay? And that the premium credits are tied to a percentage of the person's income beginning in 2014. But you might probably not know, some of you may know, that those credits are actually indexed to a level that is below healthcare costs. So that after about 2018, again, it's not exactly CPI. It'll be above that. I need to correct this slide, but it'll be something around GDP, okay? And maybe slightly below that. And so over long run, these credits are expected to grow much more slower than health spending will. So there'll be a lot of a wedge, in effect, that'll grow between the credit amounts and the mandatory coverage that people have to buy. Okay, let me get to this important point here. What do these indexing provisions really mean? Well, I did a summary slide here that shows that this Medicare productivity improvement savings in 2020 is expected to save something on the order of $80 billion that goes toward the healthcare law. Okay? That's this cut in the annual updates that occur for Medicare providers. By 2030, though, because of the compounding effect, you get this every single year, okay, going forward on a permanent basis. This is not a one-time thing. It's not just 1 year you're going to get a 0.5 percentage point off your update. It's every year on a permanent basis. If you compound that out by 2030, you're approaching $400 billion. Granted, these are nominal dollars, but still, it's going to be a huge hit, okay? And so they're expecting to take huge amounts of money out of what Medicare is paying on a per-service basis. That's the way they make the numbers work, okay? The second provision is, we didn't talk that much about it, is these taxes that they impose, again, like the high-cost insurance tax as well as the payroll tax, these taxes are imposed on more and more people over time. So that there will be a very big tax take associated with it in the second decade. That's the way they're able to pay for and make the healthcare law, at least on paper, look like it adds up. Now, back to this payment provision. The actuary, who's been pretty much a hero in my view over the last couple of years about this, wrote a memorandum a few months after the healthcare law passed, and he basically analyzed this productivity improvement cut that's going to occur in Medicare relative to what private health insurance is expected to pay for the same services, as well as what Medicaid is expected to pay for the same services. And as you can see from this chart, these productivity cuts, Medicare right now is above Medicaid but below private health insurance. So, for a unit of service, Medicare pays roughly 80 cents on the dollar compared to private insurance. Medicaid is probably around 70 cents. Okay? With these cuts in Medicare, by the end of this decade, Medicare is expected to be below Medicaid. Okay? And then it'll just keep falling and falling and falling and falling. So all of the projections that are out there that say, hey, we've got the healthcare system now a little bit more under control, Medicare is going to be better off in the future, they're all really predicated on this line. Can you really continue to just keep paying for, on a per-service basis, less and less and less to the hospital system? And maybe the answer is yes. Maybe the answer is no. It depends. Here's what the actuary said. He said, we believe that the multi-factor productivity adjustments to Medicare are very unlikely to be viable indefinitely. Now, you got to understand actuaries, right? They make accountants look really, exciting. So this for the actuary to say this is sort of, he's really trying to stir the pot, And accordingly, projections based on the permanent application of this new component of current law are very likely to seriously understate actual Medicare costs in the long-range future. parse it all away, basically saying, I don't think so, okay? Very unlikely, okay? He still says that. He's said it many, many times. Every chance he gets, every time he testifies before Congress, all around town in Washington, wherever he goes, he's been making this point. All right, let's talk about one other thing, which is important to understanding the budgetary environment for healthcare. And that is this business of the exchanges and what it will do to employer-based health insurance over time. This is a chart from some colleagues who I know from Washington, Gene Sturley at the Urban Institute, Tax Policy Center there, and one of his colleagues there did this analysis of how much a household will get in federal subsidization toward their health insurance from the new exchanges. Don't get fooled by this title. This reconciliation just refers to the final healthcare law. But this is how much people will get in an extra federal subsidization based on household income, okay? So if you're down here and you're a $42,000 a year household, your subsidy for health insurance under the new healthcare law is going to be very substantial, probably in the range of $14,000, paying both for your premiums as well as your cost sharing, okay? That comes down as your income goes up. So it phases down over time. The subsidies end at 400% of poverty, okay? So, you know, down here it is in the $4,000, $5,000, $3,000 range. Now, when an employer pays for health care today, of course, it's tax preferred. It doesn't count as compensation to the worker, okay? So there's an implicit federal tax subsidy associated with employer-paid health insurance, okay? What is the value of that? On average, it hovers around $4,000, okay? And doesn't go much above that, although it creeps up a little bit for the upper income brackets, okay? So for people down here on the low end of the wage scale, the amount of federal subsidization of their health care is going to be very, very high in the exchanges relative to the employer-based system. That to me looks like a pretty big magnet for people to end up in this exchange system as opposed to employer plans. Now, CBO looked at that and said, okay, for a variety of reasons, we don't think that's going to happen in a big way. We don't think those workers are going to migrate out of the employer plans in a big numbers into the exchanges. Their estimate is that the amount of people enrolled in the subsidized insurance exchanges in 2019 is only going to be about 24 million people, okay? Now remember, these insurance subsidies in the exchanges go all the way from 135% of poverty to 400% of poverty for people under the age of 65. That's basically like the entire American lower and middle class, right? That's a huge portion of the population. When you look at the census data, that's about 111 million people in that category. So there's potential for a lot more of these people ending up in this category. The question is how many of them, okay? And there have been estimates done by others, not inside CBO, who have said, look, we think that this number could be 50 million, 60 million, not 24, okay? If that were to be the case, then really you're off to the races in terms of additional federal spending on subsidies. My own experience is that this is way too much money for people to just leave it sitting on the table and not take advantage of it. That if they could get this subsidy and get their health care a lot cheaper in the exchanges, they're going to find their way to it one way or the other. They'll switch jobs for it. I mean, there's so much money involved, you can imagine people switching jobs to take advantage of it. As firms form, they'll probably segregate a little bit into low-wage firms and high-wage firms to maximize the number of people who can take advantage of this, as well as the high-wage people taking advantage of the tax subsidy, okay? So it may take a few years, it may take 10 years, but there will be a certain amount of sorting of the workforce that will occur to take maximum advantage of the federal money available. Okay, now the bottom line then for our purposes today is what did the healthcare law do to health spending going forward? Did it fix the problem, so to speak? And again, CBO did this very nice chart that shows sort of where we were prior to the health law and then after the health law. And so you have this blue line here, little bit hard to see, but this blue line here is where we were prior to the health law being enacted. And as you can see, just for the health spending in the budget, this is not the entire health system, but only federal health spending. We were just a little short of 6% of GDP in 2010, and that's going to go up to 10% of GDP in 2035. The healthcare law modestly increases it in the near term. That's assuming all of this healthcare cuts actually work. And then actually they say, hey, there's a point in time where it actually might cross, where the healthcare law might bend the cost curve for the federal government, right? And bring health spending just slightly below what it otherwise would have been, but still well above today's levels, okay? That assumes, of course, that this productivity factor adjustment that I've been talking about stays into effect on a permanent basis. If it doesn't, and the Medicare fee schedule gets adjusted and some other things occur, then you get this line, this brownish line that shows alternative baseline. And you can see that the healthcare law actually, under that assumption, didn't solve the healthcare cost growth problem in the budget, but actually added to it, although somewhat modestly, maybe a percentage point of GDP or so. Okay, now let's talk about sort of how I view the, at least my perception of what, what are we really wrangling about in all of this? What does this really kind of get down to? And I think it really gets down to two different visions about answering the central question, okay? And that's one reason why this debate was so contentious, is that there are actually two different strongly held views about how to get at the core issue of what to do about healthcare costs, okay? And the way I phrase it is, you're not going to answer this question in one day. It's such a complex system. You really are talking about what process are you going to put in place to deal with this question on a continuous basis, okay? And the way I phrase it is, what process has the best chance, there are no certainties in this game, of bringing about continual improvement in the productivity and quality of patient care, okay? The only way to slow the pace of rising costs in a way that will be acceptable to the public, that is, without a huge deterioration in quality, is to make the health sector ever more productive. Higher quality, more bang for the buck, so to speak. Okay? How do you bring that about on a not a one-time basis, but on a continuous basis? Year in, year out. Okay? And there are two different answers to that question. Okay? And I try to be fair and balanced here. There used to be, so there's a blue side and then kind of a reddish side. Okay? And the bill that passed was basically more or less the blue side, okay? And so what are we talking about here? We're talking about the government at federal and mainly the federal level, but somewhat the state levels, leading an effort to bring this about, leading the effort to bring about higher productivity, more efficiency, higher quality, okay? And how are they going to bring it about? Obviously through the stimulus bill, which was separate from the healthcare law, but big push by the current administration and the prior administration, the administration I worked for. Health information technology. How do we make that a infrastructure component of a new higher efficiency system? We can talk about that if you'd like, but there's a lot of complicated components to that. Comparative effectiveness research. Gentleman I met just a little while ago, part of that effort. Big push in the stimulus bill. The point being that the federal government would lead a research effort to actually do much more meaningful health services research, looking at, if you put this person on this pathway versus that pathway, what actually happens to them, and try to follow these populations on a more data-rich basis going forward. Then the ones that get a lot of attention in recent months are the Medicare-led payment reforms that are put in the bill. Okay, things like accountable care organizations, which I'll mention again in a minute, but also bundled payments to the institutional providers, to hospitals, to cover a larger spectrum of the care associated with a particular diagnosis. There are also provisions in the law about readmission rates and trying to push through that kind of payment systems to push toward a higher quality, low-cost system with fewer errors. And then there's the the IPAB, I call on here the Medicare Commission. There's the Independent Payment Advisory Board. Their charge is to find new payment models going forward to push for higher levels of productivity in the health system. Okay? Now, what are the criticisms of that approach? What do people say when they hear that kind of theory put forward? Lots of things could be said here, but bottom line is that from some people's perspective, you end up, it all sort of sounds good on paper, okay? But when you get down to application and practice, it tends to be a much more blunt instrument. That the ability to have the refined changes necessary to make these things work usually get lost in the shuffle, and the government ends up sort of saying, hey, to try to make this program work, we're just going to pay everybody slightly less, okay? And you kind of see that in the bill. It's sort of got this tension in the bill between trying to lead this higher quality, lower cost, modern delivery system approach, but at the same time, to hit budget targets, there's lots of across-the-board cutting, and there's this new IPAB, which is going to do more across-the-board cutting, okay? So then the question is the answer to our health cost problem really on the price side? Is it really a question of just paying people less? And this gentleman here made a very interesting observation that, what if you return physicians to their compensation levels from 40 years ago? It actually wasn't that bad. They made a very good living. They were actually happier. But could you do it? There's a lot of practical issues involved. But so, and relative to the international experience, we pay our providers of medical services way, way more than most countries do. So even on a per-service basis, not even accounting for volume, we just pay a lot more on a price level. So there's a lot of people who believe that some combination of price cutting plus the government initiating the effort will work. And moreover, they have one other really important factor on their side in this question, which is that most countries around the world do some version of the blue plan. Okay? The other industrialized countries around the world, we are an outlier. Okay? We have not yet adopted the blue plan in a big way. Okay? And most other countries around the world long ago adopted some version of the blue plan. Okay? Lots of variation, lots of differences. I'm not saying it's all the same, but by and large, the developed industrialized world is in the game of regulated health systems. So then the other side comes along and says, look, we think, at least in our political culture and the way we run social programs and just consistent with the sort of the American ethic and our Constitution, that the blue plan will end up being a disaster on a number of levels. And therefore, what we want to do is propose a market-based approach to healthcare reform, something that doesn't rely so much on the government trying to engineer higher efficiency, but actually relies on market incentives, much as we try to drive the rest of the economy. And how do you do that? Well, you have to do a lot of different things on the red plan to make it happen. Okay? You'd have to have probably the most important thing is for a functioning marketplace to work, you have to have cost-conscious consumers. Okay? So instead of today's tax system that provides a open-ended tax subsidy for healthcare, you'd have to move towards something closer to a defined contribution system. Similarly for Medicare, and maybe even for Medicaid, although with some differences. And so the red plan assumes moving away from the government providing extra funding for each dollar of health care toward a system where the government says, here's your fixed amount, okay? You're going to have to make some choices. If you want a more expensive, higher premium, low management system, you're going to pay a higher premium. If you want something that's more managed, more coordinated, more controlled, yes, but probably very high quality, you could pay a lower premium, okay? So the onus for the burden for cost control shifts, and the resource allocation decisions shift from the blue plan under the red plan from the government more toward a consumer-driven system. But the government's still overseeing it, still very much involved in making sure the marketplace works. Look, this will never be totally, here's your voucher, and good luck. It's never going to operate like that. What are the examples of this? Probably, strangely enough, the best example is in the government, right? Probably the Part D program. The Part D program in Medicare is the prescription drug benefit. Granted, it's only a component of the entire package, right? It's a commodity, a little bit easier to handle than big institutions and physician community. But if you look at what's happened under the Part D program, it is essentially a defined contribution system. There's bidding. The government sets the premium that it will pay at a fixed level per region, and the seniors then have to decide if they want a certain plan that costs more, they pay more out of their own pocket. So the plans that are participating all know that, look, relative to my competitors, if I don't want to lose market share, I got to keep my premium competitive, right? And it's worked pretty well. I mean, costs are coming in way below projections. Seniors actually are making cost-conscious choices to join low-premium plans. Generic substitution is way, way, way up compared to what it would have been. So the plan has actually worked relatively well. And lots of people say we need to model the rest of Medicare, and then even, frankly, beyond Medicare into the employer setting, something more along those lines. That's the red plan. What's the criticism of it? Doesn't exist in nature, right? So everybody says, well, wait a second, it's great in theory, Capretta, show me where this is going to work. You want to bet the entire healthcare system ranch on this theory, right? And, that's a pretty good argument. And I think that's really the argument that has more or less carried the day. That's why the blue team approach tends to have prevailed, although there's a little bit of a mix, but has tend to have prevailed. I think largely because the public is very risk averse. And the idea of the government promising that it'll work out to some extent is enough to sort of win the day, so to speak. So far. Okay, let's dive in a little bit more on the delivery system reforms that are in the healthcare law and how they may or may not affect the budget going forward, and then we got to talk quickly about the super committee and the current next steps. So accountable care organizations, they have to. You probably all know more about this even than I do. I mean, the new reg just came out. My impression is it's modestly better than the one that came out 4 or 5 months ago. But this was supposed to be the way that you would leverage the Medicare program to really change the delivery system through the bill. Okay, so they're betting a lot that this is going to work out over time. And the key thing to understand about ACOs is actually this provision here. Jumping ahead for a second. Not a lot of people know that the provision in the law basically said, well, how do people end up in these ACOs, right? It seems like sort of a provider-driven managed care structure, essentially, right? And then you think to yourself, well, actually, how do you end up in an ACO, okay? And the way they end up in an ACO is they essentially are going to get assigned to them. It's not really going to be a choice system. They're going to say, okay, where does your primary care physician practice? Are they part of an ACO? They'll look at this big data set that Medicare collects, and they'll say all the people that have that physician as their primary care doctor, they're just sort of automatically assigned and assumed to be part of his ACO, his or her HCO. Okay? So this is a pretty critical provision. The idea is that if a physician joins an ACO and is part of it, the beneficiaries that he treats are going to come with him automatically. Right? But everybody knows that really to run, I mean, what does this get down to in healthcare? To be very blunt about it, to run a high-quality, low-cost network, you have to leave people out. Okay? You have to leave physicians out. You have to leave high-cost systems out. Okay? And that means that if a beneficiary joins an ACO, unless it just includes everybody in the community, their network is automatically sort of constrained because that physician is going to start steering them to the people they're affiliated with, right? And without the consent, at least at the beginning from the beneficiary, I think you're running into a lot of trouble. I think the idea that you could pull that off over the long run is probably low. Now, it's probably going to be a smaller demonstration than they envisioned anyway, but I think this is a critical issue. Now, just going back again, they also have in the law the CMS Innovation Center. They got a lot of money, $10 billion, to spend on testing a lot of innovative payment systems and structures through the Medicare program, and they're actively pursuing ideas from all across the country. If you got any ideas, there seems to be a lot of money there, so you might have some way of getting at it. Then, of course, we already talked about the IPAB, 15-member Senate-confirmed group. Their charge is to implement further cuts in Medicare provider payment rates, okay? And it's going to pinch more and more beyond 2020. So they've really outsourced from the Congress to the IPAB enforcement of what's effectively a new cap on Medicare. The president, the current law says that the IPAB should keep Medicare spending at, remember the earlier chart showing Medicare going up close to 2 percentage points faster than per capita GDP over a long period. The cap now on Medicare is 1 percentage point above GDP, and the IPAB is charged with enforcing it. Okay? The president gave a speech right after Labor Day where he put some further budgetary proposals on the table for consideration by the super committee. One of them was to lower the IPAB's target from 1 percentage point above GDP to 0.5 percentage point. Okay? So one way the president is proposing to make the long-run budget look even better than it does now is to sort of double down on this concept of the IPAB. Okay? Now, this is sort of my bottom line in terms of the choices we face. And it has to do what I call it Medicare fee-for-service political economy. Medicare fee-for-service, in my judgment, is critical to understanding why the delivery system looks the way it does. Okay, that it's not the only reason why we have our delivery system organized the way it is, but it's probably the #1 reason. And within that, you have to understand that, look at the healthcare law. I think the administration even agrees with that point, right? They're saying we're going to change the delivery system of healthcare mainly by changing and manipulating the way Medicare is run. So implicitly, they're saying, hey, if you don't change the way Medicare fee-for-service is run, the delivery system is probably going to remain the way it is. Okay? So they're pursuing some changes through Medicare fee-for-service to try to make that system more efficient and accountable and higher quality. The question is, will that work? I mean, in our political economy, Medicare fee-for-service kind of looks the way it does for a reason. Which is that it pleases the constituency that's enrolled in the program and the politicians who oversee it. Okay? And why do I mean that? Why do I say that? Well, it's because that if you look at it from the beneficiary perspective, it's totally access to any physician nationwide under the fee schedule. You could go to anybody in the country. You have supplemental insurance that generally brings your cost sharing down to 0, right? 90% of the fee-for-service participants, I mean, even though Medicare has very high cost sharing, almost nobody pays it, right? Because everybody's in supplemental insurance of one kind or another. They're either in an employer plan, they have Medigap, although Medigap's changing a little bit, or they're in Medicaid, okay? So the number of people who are actually paying Medicare's cost sharing at the point of service is actually quite low. But, so from their perspective, what's not to like? Then from the Congress's perspective, every physician and hospital in the community is basically treated the same, right? They don't have to pick and choose amongst them. They're all sort of treated equally. Everybody gets the same payment. If you're a licensed provider, you participate in Medicare, you get the same payment as the guy down the street, okay? Come into that environment and say, we need to go toward a high-value, low-cost system, okay? You automatically are in the business of picking and choosing, okay? You're automatically in the business of trying to do metrics that determine who are the high-value, low-cost people and who aren't, okay? And you have to measure that in some way. And we've had many examples of Medicare trying to go down that road. I can tell there's some people in this room who are old enough, not just me, to know that there was a program in the 90s called Centers of Excellence. Anybody remember that? Okay, so Centers of Excellence was launched in the Bush 1 administration, trying to push through Roper and other people were pushing, like, let's designate certain high-value hospital systems that do certain high-volume procedures very, very well, okay, at a low cost. And we'll designate them centers of excellence, and then subtly but surely over the time, we're going to steer the Medicare patients to them, okay? So instead of Medicare patients going to get their heart procedure done at every little community hospital around the country, we're going to find the ones that are doing it, in high volume and really well with low problems, and we're going to steer the patients to them over time, okay? So they announced the demonstration. They put out the initial list. They say, we're testing the waters on this, and lo and behold, somebody's not on the list, okay? Someone who self-perceives them to be a center of excellence, okay? They happen to be located on a big Midwestern lake, and they're consider themselves very, very good, okay? And so they go to Washington, and they said, hey, your centers of excellence demonstration is terrible, You've got it all wrong. Your data is bad. It's not quality. It's not risk adjusted properly. It's impossible that the hospital 100 miles away is better than us on this. They're terrible. Okay, you've got it all screwed up. And so they went to the Congress. They raised a big fuss. There were other people with them. The coalition was formed. They killed it, basically. Now it still exists in some kind of dormant sort of way, but it never really had any teeth. Okay. And that's because in the political system, they kind of like it this way. They like not having to pick and choose amongst everybody. I call it the Lake Wobegon effect, right? Everybody's slightly above average, right? And if you look at the way Medicare is run, and we've had a lot of demonstrations, and they always tiptoe up to really making some hard choices, right? But they eventually rate everybody slightly okay. Everybody is, right? So you can never steer. You can never really say to the delivery system, hey, we're going to really just go with the really top performers. And so the bottom 20% never drops out of the program. I think that's the critical issue. Okay. I really have to hurry now because I want to get to Q&A. But, okay, so now we've gone through all this huge debate, and we're still fighting over all these questions. That's my sign that my time's up, huh? Or the talk's getting boring. Okay, so we have this super committee still sitting out there, and they are charged with notionally $1.5 trillion, but really they got to come up with $1.2 trillion to avoid this sequester that would occur in 2013 and every year thereafter until 2021. Who's on the super committee? The chair people are Jeb Hensarling, congressman from Texas, and Senator Patty Murray from Washington State. Camp and Upton are the big committee chairmen, Ways and Means, Energy and Commerce on the House side. You probably know these senators: Kyle, Arizona; Portman, Ohio; Toomey, Pennsylvania. Baucus is the chairman of the Finance Committee. Senator Kerry, we all know. Clyburn, Becerra, and Holland. Holland is the minority rep on the Budget Committee in the House. All three are very close to the House leadership and Speaker Pelosi. For any recommendation to move out of the Joint Committee, remember now, the big thing about the Joint Committee is their recommendations automatically are considered for an up or down vote in the House and Senate. In the Senate, that's a big deal. It can't be filibustered. So it's a majority vote in the Senate. So you avoid 9 votes, basically. You can pass something in the Senate with 51 instead of 60. That's what really this is all about. Okay? And but to get that, you have to have 7 people of these 12 agree to a recommendation. Okay? So someone you got to get you got to raid the enemy line and grab a hostage or something to that effect. Okay? Or get a willing defector. Okay? So that timeline is that has to happen by December 23rd. That is, the president actually has to sign something into law by December 23rd. They have to recommend it by the end of this month. Otherwise, the sequester hits, and it doesn't hit, though, until 2013, as I mentioned. 50% will come out of defense, 50% out of non-defense plus entitlements. Now, for this purposes, what you need to know is this sequester could hit Medicare, but only up to 2%. So all the cuts that are in the healthcare law that we've seen, you could be facing another 2% cut from this sequester. Okay, so if the payment was going to be $100, it'll now be $98. Medicare Advantage payments included. Okay, not any effect on the beneficiaries. Medicaid is exempt, but some of the other provisions of the healthcare law are not exempt. Some minor provisions. The cost-sharing subsidies, some of the public health funding, NIH is not exempt. So lots of non-entitlement discretionary accounts could get hit. Okay, the expectation is if this sequester hit, it would be about a $50 billion hit out of defense, $50 billion hit out of the non-defense side. Okay, I think the big political problem is actually non-defense will be important, but the big political problem will be defense. That the idea you're going to take $50 billion out of defense in January of 2013 with, so much turmoil and conflict still underway, hard to see it happening. Okay, but that's what the sequester would call for. So there's lots of pressure on the super committee to do something different. And what are they looking at? I don't think they're going to get at this question, the fundamental question I said that's really at the center of the debate. Are we going to move to a defined contribution system? Are we going to do something different from the healthcare law? I don't think they're going anywhere near any of that. They don't have enough time. They don't have enough expertise. It's too budget cutting emphasis. It's not long-term focus. It's the next 10 years. Okay, and so they're going to end up probably. President Obama put a number of things on the table for them to cut. The Democrats actually offered, and this came mainly from Senator Baucus, to take $475 billion more out of Medicare and Medicaid over the next decade. It was unspecified. Half would come out of providers and half out of the beneficiaries, but we don't know how. Let me just say, I think I know where most of it would come from. People who operate health systems. Anyway, that's sitting there on the table. The Republicans rejected it because it came with a big tax increase too. President Obama, his proposals have been more specified. There's a thing called, for your purposes, they want to put into the Part D program some of Medicaid's rebates for prescription drugs. That would save a big chunk of money. They want to cut hospital payments to rural providers, a bunch more. But again, getting that through the Finance Committee would be tough. They want to cut hospital bad debt payments. And there's some other things, some post-acute payment reductions, some small Medigap reform that would affect the beneficiaries. On the miscellaneous side, the Republicans are pushing, I would say, mainly two things. Major Medigap reform. So you say you can't have first dollar coverage through Medigap plans. That would be a big deal. Okay, I think AARP will come pretty unglued from that proposal. And then Senator Lieberman and Coburn put on the table a major restructuring of the cost sharing of Medicare Fee for Service. Republicans are actually embracing that in the super committee, and that is a possibility. I put all of this at relatively low odds in terms of big change. I think what we're going to end up with is nothing that looks like it entrenches the healthcare law, because Republicans will be against that, but some minor cuts that add up to $300, $400, $500 billion in Medicare and Medicaid that both sides can basically live with, and then add to that some minor corporate loophole closing and some other things, and then call it a day. I think they could do a package like that by the end of this month, and both sides would say, this is the good as we can do. I don't think you're going to get a grand bargain, though, that solves these questions once and for all. I really think I've gone too long because I want to do Q&A, but maybe Paul can moderate that. Thanks.
Why don't you stay up here?
Okay. Yeah, happy to take questions. Yeah. That's fine.
So in the sequester, it's trillion two, whatever it is.
Trillion two.
And you got half of it. What about the other half?
Well, the other half, remember, the sequester doesn't hit. Let's say you did a $600 billion package. That would mean that they would schedule a sequester of $600 billion divided equally over 9 years, 2013 to 2021. And so that would mean, roughly $60 billion, $50 to $60 billion, not counting net interest savings, in 2013. We're going to have a presidential election between now and then. A new Congress will be forming in January 2013. I think you would very likely have impetus to say, hey, let's do something to avoid the sequester, and then sit down after 2013, in 2013, early 2013, and do another budget deal. I think the timing for, if there's ever going to be a grand bargain, it'll happen in the first 6 months of 2013.
So they kick the can down
Yeah.
the road a year.
Correct. Exactly. Anybody else got something? Must be, yeah.
Yeah, I've got a question. On your exchange enrollment versus eligible population, did they factor in like employer plans that support pre-65 retirees? Because the graph shows there are a lot of pre-65 retirees that would get significant subsidies.
Yeah.
If they opt out.
Yeah,
What
they
was their
did.
thought? They did.
They did.
Okay.
But you know, they only assume about 5 million people are actively working and had an employer plan with coverage that are going to end up in the exchanges. That's the number I was really focusing on. A lot of people think that could be well above 5 million. But they did assume the early retirees who would be better off in the exchanges end up there.
Yeah.
Yeah.
On the double counting issue, I'm curious why the CBO or the Medicare Actuary wouldn't have caught that or highlighted that, and
They knew about it.
they didn't
Well,
put
it's,
it in the numbers.
it had, well, they did. I mean, here's the deal. It's sort of a statutory thing. It's baked into the way federal accounting works. So you can't really blame CBO or the actuaries. It's just the way it is. In this particular case, the numbers are so big that it's consequential. You know, it's been this way for a long time, but in this particular instance, you look at it and say, this is kind of crazy, because you're going to end up spending $500 billion twice, okay? And they said it, they agreed with it, but it has to do with the accounting. The federal budget is accounted on, doesn't account for these trust funds separately. So when you cut something that makes a trust fund look like it has more money, plus the budget looks better, you end up counting it on both books.
So it's bogus.
I know. I'm just telling you. Yeah. I guess I've lived in Washington too long. I'm used to it. We need to import people who actually get more outraged. Yeah.
If you were a betting man, where would you put your money on the SGR fixes this year?
It'll happen. Yeah, it'll happen. It'll happen every year. Yeah. So I don't spend a lot of time worrying about it. I know a lot of you do, but it'll happen because it has to happen. Everybody wants it to happen. It's a question of maneuvering and who's going to, who's got leverage to get something else in addition to it. That's what's going on. I mean, there's going to be some kind of deal at the end of this year, regardless of the super committee. I don't think they'll let the payroll tax expire. I don't think they'll let extended unemployment insurance expire. And I don't think they're going to cut doctors. I think all three of those things are must-do things. And it's just a question of, the dancing that goes on to kind of make it happen relative to the super committee. Yeah.
Yeah, I'm a little bit confused by all of this. We have in Southern California